And it starts off as the what? Stem. Right? So what we need to do is to find this stem, right? But look here now. So guys, this is the lateral surface. This is the superior border. And resting on my hand is the inferior surface, right? And then this, of course, is the medial surface. So once we come to the medial surface, we can actually see the inferior surface, right? That's resting on my hand. And look, this is the stem of the lateral sulcus. See it here? See it?
Yeah.
See it here? So this is where it starts. Let me take off this little piece and try that. So it starts actually here, and you can see it's running laterally, right? So this is the stem of the lateral sulcus starting here, and it's running laterally, right? And then now, as it goes laterally, it's going to find itself between this and this. This is the temporal lobe, that's the frontal lobe, right? So the idea is this now. As soon as the lateral sulcus gets to the lateral surface, which is right here, look what's going to happen. As it gets to the lateral surface, it divides into a anterior what? Ramus, and then ascending ramus. Good. So anterior ramus, ascending ramus. See?
That's Sylvian's point.
Yes, so that's a sort of exquisite. We'll leave that alone for the time being. So we'll come back to the Sylvian point argument. Oh, you see it? Good. And then it continues as the posterior limb or posterior ramus. So the lateral sulcus has an anterior ramus, an ascending ramus, and a posterior ramus. Okay? But of course, sometimes, you know, sometimes we just casually call the posterior ramus the lateral sulcus. But as you know now, that's not totally so, right? Give me the other name for the lateral sulcus. Exactly, Sylvian fissure. So the lateral sulcus is also known as the Sylvian fissure. But I must tell you, in neuroanatomy, fissures tend to be reserved for the deep, deep sulcus or sulci. And I guess, look, because this is deep, see that? Maybe that's why they call it the Sylvian fissure. Look how deep it is. See that? You see that, miss? It's quite deep, right? All right, good. Now, so in green now, what I'm going to show you now, that the anterior ramus and ascending ramus, look what they have done. They've divided the inferior frontal gyrus. Remember, this is inferior frontal, right? Because how we know it's inferior frontal? Because the frontal lobe has a superior frontal sulcus, inferior frontal sulcus. So this is the superior frontal gyrus, middle frontal gyrus, and inferior frontal gyrus. So these two limbs have divided the inferior frontal gyrus into an orbital gyrus, right? A triangular gyrus, which is this one here. Look, so we said this is the anterior, this is the ascending, right? So this is the triangular, and then this now, that's green, that's the opercular gyrus. So three of them, right? So this, of course, is still in the what? Ascending ramus. Good. See that? So why have I gone out of my way now to show you all of these things? There must be a reason. So again, this is the orbital, triangular, and opercular, right? Broca's motor speech area lies between the triangular and the opercular gyrus. Okay? Opercular. They got nothing to do with what? The orbital gyrus. And of course we say, oh, what's the word opercular mean again? Lid.
Because it has more than one operculum.
What about that?
It has more than one operculum.
What? The brain? Yeah. Yeah, we talk about that. But look, lid, L-I-D. And you shouldn't be asking me because you just did what? Man health. And in man health, there's a worm called Ascaris. That worm has an egg that has a lid. Not true?
Yeah.
Good. How do I know? I love parasitology. Once in a while I read up my parasitology. Just to remind myself of those nice days. Alright, so you see that? So Broca's motor speech area now. So look here guys. Anybody ask you, and you want someone intelligent, say, Broca's motor speech area is located in the inferior frontal gyrus, specifically between the triangular and the opercular gyrus. Full stop, 100 pounds. Now this Broca's motor speech area, as you know, is also known as the expressive language area. Expressive. Good, so we're going to clear with that, right? Come look, I'm taking these pins out now. The other thing I showed you guys is this. I showed you the central sulcus. That's the what? Central sulcus. So the question somebody might ask is, but how you know this one is not the central sulcus? Well, the word central means that it's roughly located in the center of the midline. See that? So this one look like it's way behind the midline, right? Remember we said that the central sulcus cuts the superior border roughly about 1 centimeter behind the midpoint between the occipital pole and the frontal pole. So if I were to draw a line from there to there, I would say roughly the midpoint is right there. But this midpoint will be too far back, right? And of course, this one will be too far forwards. And the other thing about this one, it don't cut the superior border. Is it? Yeah. So this would be the prefrontal sulcus. Precentral sulcus, sorry. Central sulcus, postcentral. But this one don't cut the superior border, so that don't qualify. You see? The other thing I should tell you now, guys, is this. Look.
Someone, can you like tilt your hand a little bit as well?
Okay.
Yeah.
Like that?
Yeah.
Wow, my neck is. Anyway, look. The other thing about the central sulcus, if I could open it up, and you'll see that is roughly about 2 centimeters deep. It's deep, look. See? It's deep, right? So, pretty much a lot of the primary motor cortex going to lie in the side wall. So we know, we said this is the precentral gyrus, right? And it's the primary motor cortex, right? But we often just said this is it. This is it, yes. But look, some of it lie inside here as well. See that? So some of the primary motor cortex lie inside here. So deep in the central sulcus. You get me?
No,
So look, look. So remember we said this is the precentral gyrus, right?
Yeah.
All of that. But I'm saying that this is the precentral gyrus too. That part of it.
Okay, so
You understand?
you mean
The,
here
yeah,
and then
yeah, all of inside here go all the way
Okay.
down, right? You understand? In other words, the point I'm making is a lot of the surface of the brain is hidden from view because of these sulci. You get that?
Yeah.
Okay. Everybody see that? Good. The other thing I want you to notice about the central sulcus, look at it. So it comes down, it's coming down, and it stops short of the lateral sulcus. It don't come down and touch it, it stops short. But look on this one going all the way down. Right? So the central sulcus runs downwards and forwards. It's not going downwards and backwards. And it's not coming vertically straight down like that. It's coming downwards and forwards, stopping short of the lateral sulcus. Okay, great. Then now, if I were to put the green pins in this, you would say, sir, the green pins are in the postcentral gyrus. Good. And if I were to put these pink pins, you would say, sir, pink pins are in the precentral gyrus, right? You get that? Yeah. So look here now. Look how I'm going to switch it around now, like that. So the green pins are still in the postcentral, right? And the pink pins are in the precentral. You agree? You agree? So in other words, this is still postcentral gyrus. So this is postcentral gyrus, but it's the extension of the postcentral gyrus where? On the medial surface. And this is still precentral gyrus extending on the medial surface. Okay? Now this entire continuum here, this entire continuum that we're looking at, where the back part of it is postcentral and the front part is precentral, the entire thing is known as the paracentral lobule. Okay? So you can say the paracentral lobule is the medial extension of the precentral and postcentral gyri, right? You get me? Good. Now, Let me ask you a technical question now. Look at this brain here. If I put it this way, I can put it so to match it with my head, or I can put it so to match it with this head over here, right? So which, and I'm doing it just to help you to figure out which hemisphere it is. Remember now, this is the front of the brain, that's the back. So which hemisphere is it? It is the right hemisphere, right? In other words, the green pins are in the right posterior limb of the paracentral lobule. You get me? Or you can just say it's in the posterior limb of the what? Paracentral lobule in the right hemisphere. So if a man comes into you with that lesion in the posterior limb of the paracentral lobule in the right hemisphere, what do you expect when you examine him at the bedside? What are the deficits you expect to find in this man?
Left side.
Left side what? You mean left side of the face?
No.
So you can't say left side then. Of the body? Yeah, so left what? Left lower limb what? Left leg what? So what is the diagnosis you're going to have? Left lower limb? Yes, so loss of sensation to the left lower limb. No, remember motor is precentral gyrus.
So you're talking about
Oh man, green pin, posterior limb. Now posterior limb is good. Have a listen. Right, Liz? Good. If there's a lesion in the posterior limb of the paracentral lobule, the patient is going to be diagnosed with contralateral loss of sensation to the lower limb.
Can you repeat that?
Yes, so a lesion in the posterior limb of the paracentral lobule is going to result in contralateral loss of sensation to the lower limb.
That's
right?
a somatosensory.
Yes, somatosensory. So going to be loss of pain and temperature, loss of proprioception, vibration, sense, 2-point touch, all these things. These are all sensation, right? Mm-hmm. Would there be loss of taste? No, because this don't have nothing to do with tongue, right? It have nothing to do with tongue. It has all to do with what? Lower limb sensation. On the other hand, if the lesion were in the area where the pink pins are, then there will be what? No, give me the same thing like oh, Miguel, give it to me same way. There are loss of. Yeah, give me a more polished way to say it. Give me a more polished way. Contralateral hemiplasia, or you can say contralateral muscle weakness of the lower limb.
What's
okay? Hemiplasia is just weakness of one side, right? So if you want to sound exotic, you can say that. But if you want to be simple, just say contralateral loss or contralateral weakness of the lower limb. And when we say lower limb, what are we talking about? The leg? No. Talking about the thigh, knee, leg, foot. Remember, lower limb is not just leg, you know. The thigh is lower limb, the knee is lower limb, the foot is lower limb, all the toes.
So we wouldn't get full paralysis though?
No, weakness, just weakness. That's a better. In fact, the word they use is paresis. Hemiparesis. Or you can just say, if you're going to say contralateral, you're already saying hemi. You get me? So if you want to be precise and don't be too wordy, you can just say hemiparesis, right? And it's going to be contralateral hemiparesis. That's so you have explained the thing in few words, but if you're wordy like me, you can just say contralateral weakness of the lower limb. That's many more words, right? Everybody get that? And remember, yeah, because remember now that the lesion would be in the cortical spinal, is in the precentral gyrus, and the pathway from there is called the cortical spinal tract. But that's not the only motor pathway. There's a reticular spinal tract. There's the so-called basal ganglia. All of those are involved in motor, right? So you can, and in fact, we see it all the time in the literature with the patients and so on. Them get this lesion, and initially, them have this profound weakness, and with time, them get stronger and stronger, right? But it's still very weak. And so when you do your examination, you get them 3 out of 5 or 2 out of 5 or whatever. But often they don't get 0, right? For them to get 0, it has to be profound and also disruption of the reticular spinal tract and so on. So you can get an experimental animal like a mouse and sever him cortical spinal tract and him paralyzed, and you leave him in the cage and the cage open, and you go home and come back tomorrow, you can't find him. Right? Once the reticular spinal is okay, pick up and go about the business. Right? The cortical spinal tract also has to do with precision movements, too, and what we call synergy of movement. Later on, we'll talk to you about that. And the cerebellum is mainly responsible for that. But fine movement and accurate movement, cortical spinal tract. So you'll find that these people become clumsy and so on when they have hemiparesis, right? So remember now, guys, you now have to be precise in your answers. You can't say contralateral weakness, because we don't know what that means. It could be contralateral weakness of an eyeball, or in tongue, or in pharynx. I don't know what you're talking about. So you have to say contralateral lower limb weakness, or contralateral weakness of the facial musculature, contralateral weakness of the upper limb, or something like that. You understand?
Can you go over the last two things you just said?
Yes. So, pink. So every time you get a brain, your first job is to look to see where the front and the back is. Okay? This is the back, that's the front, right? So it means that this would be the precentral gyrus, and that's postcentral gyrus. So if we look back again, we'll see it. This is the postcentral, and the extension of it on the medial surface is the posterior limb of the paracentral lobule. This is precentral gyrus, extension of it on the medial surface, anterior limb of the paracentral lobule. So you must remember, the paracentral lobule is this U-shaped structure, which is the continuation of the postcentral and precentral gyrus on the medial surface, right? And it's the limbs. So how you know it's the limb? Because we do that. And we say the body is represented as being what? Inverted. Remember what we said? So we said the man head.
The homunculus.
His head is down. Yeah. So with respect to the precentral, there's a motor homunculus represented there. With respect to the postcentral, a sensory homunculus. And both of these homunculi are doing what? Lying down upside down. Then head down here, then upper limb and trunk, and then the lower limb hanging down there. You get that? Good. And so next time also with the blood supply, you're going to notice that a big vessel runs in here. That's called the middle cerebral artery. You don't have to write because we'll do blood supply. But this middle cerebral mostly supplies almost all of the lateral surface. The only part of the lateral surface it don't supply is the occipital lobe. That's supplied by the posterior cerebral artery. Okay? So why am I telling you that? You can get the same result if you have an infarct in the middle cerebral artery. If you have a clot lodged in it or something, and it means that it's going to prevent blood from supplying the lateral surface. And so the precentral and postcentral now we're getting a blood supply. And the same thing going to happen again. The neuron's going to die and the man will have contralateral weakness. Right? But this time it will be contralateral weakness of the upper body musculature excluding the lower limb. Because around here is a different vessel supply. This way, it's the anterior cerebral artery supplies around here. Okay? So you have to be very precise when you give your answers. You understand?
Yes.
Okay, good.
So the lesions, you said, how do you describe the lesions?
No, I'm just saying that, so a man comes in, I'm a 75-year-old man, his son brings him to the A&E and says that, from last night, I noticed that my dad complaining of weakness on the lower limb on the right side, weakness, or say the left side since this is the right hemisphere, right? So on the left side, weakness, and he has headache and whatever. And so they bring him in now. And one of the first things they normally they do a physical examination and then notice that indeed this man have 3 out of 5 for power for the lower limb, 3 out of 5. His reflexes are sluggish, and him get 2 out of 5 and all these things, right? And you do everything, you do all the joints, your hip joint, knee joint, ankle joint, everything reduced. Power in the thigh reduced, power in the leg reduced. Yes, he says, sir, when him lay down in the bed, and the foot is like that, what you going to do? You put your hand here and say, sir, can you press like you're pressing on gas? Like that, you're supposed to do this. And I'm doing it and you're not getting any feel resistance at all. And you realize that you have weakness, right? And then you take your patella hammer and you do the patella reflex and it's lazy and so on, right? Then now you say, okay, you know what? I'm going to send this man off to do a brain MRI. When the MRI come back, you see a lesion right here. Right? You see a lesion. Let's say you see a lesion here. What did I tell you if you see a lesion here?
Shouldn't that be like
No, yeah, but what if you see a lesion here? What does that say? That lesion does not reflect your thing, right? Let's say you see a little shadow here. That shadow doesn't reflect your examination. But when you look, you see a big shadow right there. that reflect what you're picking up, right? So you have to be smart now, Sometimes, the little things happen. The MRI is not a perfect thing either, and the imaging things are not perfect, right? Little things happen here and there. But the point is this: whatever you get from the imaging must be congruent with what you get from your examination, right? So when you look, you see a big shadow in the anterior limb of the paracentral lobule, and from your examination, that's what you get in. You get in weakness of the lower limb. You get in problems with the patellar reflex and so on, right? The man can't press gas when you tell him to press gas and so on. When you lie down, you say, "Sir, can you lift up your legs yourself?" You have difficulty doing that.
But you get a Brainstem scan as well?
Yeah, so normally when you're testing power, you want to see what they can do themselves first. So gravity, gravity is a terrible thing, When I'm lifting this up, if there was no gravity, I could fling it all the way up there, right? So sometimes they're lying down and them can do a little thing, But then no, you do a little resistance now. Just put your hand on it and tell them to do it, and they can't move none at all. The best them can do is a little sideways movement, right? So you get them 2 out of 5 or 1 out of 5 or whatever. But that is congruent with what you see in the imaging now. And they sometimes ask that, man presents with lower limb weakness. Upon imaging, a lesion is found in which of the following? Anterior limb of paracentral lobule, posterior limb. They might tell you the most lateral part of precentral gyrus, the medial part of precentral gyrus. So which of the following would you expect to see the lesion in? Them say, so you see this? You see the precentral gyrus here? They often describe it as having a lateral third, a middle third, and a medial third. The medial third is the part hanging down. Right? You get that?
Yes.
So they will say, no, would you expect to find the lesion in the lateral third? The answer is no. If it's lower limb, obviously it can't be that. Would you find it in the middle third? No, that's the upper limb part. Would you find it up here?
No.
No, you find it on the medial surface. So that's how you must think about it. Everybody agree? All right, let's move on now. So we say, I'm standing up now, so sit down. All right, so that's, we said was the what? Central sulcus, right? All right, so what would you say this is? Is that the post-central sulcus? This sulcus here. What is it? The what? Parietal sulcus? What is it?
Occipital.
No, sir, that's garbage.
That's the parietal occipital.
What is it? No, that's the intraparietal sulcus. Okay.
Yeah.
And where we say it extend from? We say it extend from the post-central sulcus backwards.
Yeah.
You agree? Good. And what does it do? Divide the parietal lobe into a superior parietal lobule and an inferior parietal lobule. Do you get it?
Mm-hmm.
Yeah?
Yeah.
All right. Good. So let me put the pin now. Yeah. So the intraparietal sulcus, everybody. The intraparietal sulcus runs backwards from the post-central. See the post-central sulcus here, and it's running backwards. See? Everybody? And it now divides the parietal lobe into a superior parietal lobule and an inferior parietal lobule. Oh man, I'm getting tired. So let me put the pin now in the superior parietal lobule. So all the pins are in the what? All the pink pins are in the superior parietal lobule. Everybody see that? See there? Superior parietal lobule, right? Okay, so give me one word that encapsulates the function of this lobule. Stereognosis. Good, stereognosis. Stereognosis. And what gnosis means again? Knowledge. What? Good. So you have agnosis, or what we call agnosia, which is what? No knowledge. And then nausea now is knowledge. So you have nausea. All right? Everybody get that?
Yes.
Now, when somebody, so this is stereognosis. So what is stereognosis, really? Let's discuss that. What is that?
Awareness of his space.
Yeah.
What is stereognosis?
Spatial awareness.
Spatial awareness.
Spatial, what means you mean aware of this big space in this room?
Your awareness where your body is.
So you're right, so awareness of your body parts in space. Okay? Awareness of one's body parts in space.
Is it the same as proprioception?
No, but it is proprioceptive information now that allows us to be aware of our body parts in space. So that proprioceptive information is coming to the superior parietal lobule.
Alright.
Okay? You get that? You get that, sir?
Yeah.
Good. Mr. St. Kitts and Nevis?
Yeah, you can say that.
Okay, good. Now look here now. So which pathway you think? You haven't done it yet, but I like to talk the same thing over and over until you get it perfect. When nobody else just come in 5 seconds. So which pathway you think will convey this proprioceptive information to the parietal lobe? The dorsal column system, also called the posterior column system. Everybody get that? Right. So what are some of the, give me the modalities. We call it modalities, you can call it sensations that travel in this pathway. So fine touch, what else? Proprioception, what else? Pressure and vibration sense. Okay? Good. Good. And then now I can go further now and say, okay, so which receptors are responsible for conveying, say, the pressure and the vibration? Pacinian corpuscles. Where do we find these corpuscles? In the skin? In the skin of what? Scalp? No, where you find them? You can say you find them in the skin of the palm, but don't say skin, right? Skin of palms. But you also find them in the joints. Find them in the joints, you know. You can find them in the bladder, in the wall of the vagina, and so on. So why do you think you would find a Pacinian corpuscle in the bladder? So what pressure, what gives?
When you have the urine in the bladder.
So how the urine cause pressure? Yeah, so the urine has a weight. I remember force can be translated into pressure, right? Good. You get that? Yeah, so that's the thing. So why you find it in the vagina?
Sex.
Huh?
I don't know.
Yeah, I remember the vagina is exposed to pressure too. No, seriously, right? You agree?
Yes, sir.
So anything that is exposed to pressure would have Pacinian corpus. Why do you think you wake up in the night with the sensation to urinate? You know, urine wake, when you want your bladder full, you wake up, you know. That information passed on to your brain and you wake up over urinate. It's the pressure. It's the pressure that puts stress on the wall and it sends the signals, right? So anyway, these are the modalities that travel in the what? Dorsal column system. Now, so we talk about Pacinian. What about 2-point touch? Which receptor? Mycinous corpuscles. Where do you find those? Especially in the skin of the palm, right? We also find them in other places, but they're more concentrated in the skin of the palm. What else? So what about proprioception now? No man, garbage. Give me the receptors. Give me some names. Muscle spindles, Golgi tendon organs, and what else? Joint capsules. Good? So it is those proprioceptors that sends the information off to the parietal lobe, specifically to the superior parietal lobule. And that information is used by the brain now to identify our body parts in space. So when we're walking and chatting, we don't have to look to see where our legs are. We know where they are without even looking. You get that? We know where they are without even looking. The other thing too, guys, is all these receptors in our hands, mycinous, the Pacinian, and then I say somebody mentioned Ruffini's nerve endings and all these other mechanical receptors. These receptors pick up a whole heap of information from little objects that we hold in our hands from time to time, right? So for example, the very first time I hold a forceps in my hand like this, these receptors send all the information up, right? So write this down, each object, guys, has its own characteristics, as you know. So each object placed in our hands have its own weight, own shape, its own three-dimensionality and texture. And you know what are the things that give texture to an object? Little bumps and grooves and all these things on the object contribute to its texture. You get that, Lisa? And of course, these little bumps, are some little bumps that are close by and that pick up by the what? Mycelius corpuscles. You get me? A little ant with 6 walking legs. What ants have how much walking legs? 6, right? Yeah. Oh, you know. What ants are? Insects.
Sure.
Okay. Spiders have how much? 8. But these little legs are close together. So when they crawl on your skin, they represent little points that touch the skin. 2-point touch. And they might speed them up again. They have a weight for signal corpus to pick up that pressure. Okay? And send all this information out to the brain. And the brain now is able comprehensively to assess all this information and make a diagnosis. And it's making this diagnosis based on what? Prior experience. So the first time, you do biology class and you get to hold a forceps. That information gone straight up to your parietal lobe and it's stored there. Next time you come to me and I say, close your eyes. I'm going to put something in your hand, tell me what it is. And I'm going to put it in your hand and say, oh, this is a forceps. And you never ever see it. Right? But if you get a damage to that pathway, either the dorsal column system or the superior parietal lobule, I put the same forceps that you identified yesterday in your hand. Tell it to close your eyes and put it. So what is this? You tell me it's a shoes, book, it can, stone, you don't know what else. No, as a doctor, so this man brings him 75-year-old father in, so that him driving and wasn't involved with seatbelt on. A cow run across the road and him step on the brake. And of course, according to Newton's first law of motion, yeah, stop. But we don't stop. Sure. And when him ever stop? When him head lick up on the windscreen. And him head lick up on the windscreen right here. And it's a hard blow, right? And you carry him to the hospital. But of course, usually you say, go out to the hospital, too far. Let's carry him to Dr. Solomon's practice, which is 2 minutes away. Come to me now, he's a little private practitioner. I have none, all I have is a bed and some little gauze and alcohol and 1 or 2 little flashlight and so on, right? So him come to me now and I take a good history and find out from the history that I'm getting a big blow right here. When I look, I see blood and some hematoma and all that stuff. Mr. Brown, are you okay? He says, yes, but he's feeling a little pain here. And I said, shit, what the hell can I do? Okay, maybe I can test to see if I'm having a proprioceptive damage. I said, Mr. Brown, can you hear me? Him say, yeah. I said, can you open your hand, please? Him open his hand. I said, close your eyes. I'm going to put something in your hand. Tell me what it is. I put a pencil. I said, I tried to find something that I know he would have helped many times in his life. I said, what is this, Mr. Brown? Shoes, book, stone, and blood. So I get suspicious now. I said, boy, this looks serious. I said, sorry, I'm going to have to, refer your father to the new hospital, to the neurology clinic. Because I think he may have some brain damage. Right? So I write a letter now to the neurologist and say, please accept this patient. He was presented and so on, so with a history of having a lesion to his head, blah, 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 right? Consult and read it, do examinations. This intern was trained at uni, he's a good guy. Right? We never give two Panadol and say it. You understand? It's terrible. Now look, when I place the thing in his hand and he's unable to pick up the information from the receptors, you know what we call that? Tactile agnosia. So write that down. Tactile, of course, has to do with the skin, the receptors in the skin. Agnosia is no knowledge. So this man has no knowledge of the information going up to the brain from the receptors. Get that? And don't worry, guys, I'm going to say these things over and over and over. I want to say these things. The beauty, and by the way, if you ask the people in class of 2000 and this, 2000 and that, they have tapes of us, One girl, I was walking up with the other Solomon the other day, and this guy see her and hug her up and says in French, she's a medical student, So I said, oh, I want you to meet my friend, Calvin Solomon, and this is Everett Solomon, right? This is me. So I said, you know me? She said, no, but I know him, because I studied neuroanatomy from his tapes, Calvin Solomon. So I said, that's not me, this is me. You don't teach no neuro, it's me. But this audio thing, I have no picture. And he used to come down and sell books from the book jungle thing. So the medical students know him.
Yeah, just associate.
Yeah, so associate that person, you don't know me. But the point I'm making is there's a whole heap of audio tapes out there of me and Mr. Gardner. In fact, I hear that we're even on YouTube. Huh?
You are.
Why? How come it's that's not fair. I don't never see myself on YouTube yet. You ever see me there, Riz? My gosh, terrible. Copyright. We get some copyright. Anyway, so guys, sometimes astereognosis, so the word astereognosis, and when you're reading the book, you'll realize that a lot of the authors use it interchangeably with tactile agnosia, so it's basically the same thing. But of course, tactile agnosia conveys something to you. If you don't know anything about biology, you say, tactile, that has to do with skin. Agnosia, no knowledge. You understand? So you can probably work that out for yourself. Now, the superior parietal lobule allows us to appreciate our body parts in space and so on. And sometimes a severe form of astereognosis, I've told you before, is called what? Cortical neglect. So write that down. So there's a severe form of astereognosis called cortical neglect, where the patient not only is unaware of our body parts, but even deny the existence of parts of our body, including the visual field on that same side. Can you imagine that? So when that patient looks through the mirror and sees herself, she cannot associate one side of her body belonging to her, and she's not blind. Both eyes are working perfectly. And I told you the story of these two psychiatry students who told me that they got a test in one of the exams where they have two patients and they must figure out what the patients are. Both of them have some neurological thing, but they give the two patients a house to draw. And one of the patients draw half a house. Right? Now that one who draw the half a house has cortical neglect. Get me? Because she cannot spatially orientate half of her visual field. It's terrible.
Still doesn't really make any sense.
Don't make any sense. Doesn't make any sense. But that's it. You have to just accept it. It's just like I have a friend, same Dr. Williams there, who come and teach you guys. So we're talking about schizophrenia. And we're talking about where schizophrenics hear voices from. Right? And he can't appreciate that these when they say that they hear voices from inside their head. His argument is, why, if you are the doctor and you're taking the history and him say, him hear voices, and he says, sir, are you hearing the voices from in this room? Or were you hearing the voice? And he said, no, I'm hearing them in my head. My friend Williams can't understand that. He just don't understand how somebody can be hearing voice from inside their head. And I'm trying to explain to him that inside the head, because that's where the brain is, and that's where Wernicke's area is, in the head. And Wernicke's area is sending electrical impulses to Heschl's convolution, and you hear the voice. I remember now, when I talk to you, that vibration thing is going to set up an action potential when it gets to the auditory receptors in your cochlea. Action potential, and it's that electrical signal. When it gets to the Heschls, make you hear my voice. And it's the same electrical signal going come when the information come from Wernicke to Heschl. It's a similar electrical impulse carry the information to the cochlea and the man hear the sound. You understand? It's hard to understand, yes, and maybe it's hard because you guys are just what we call neophytes. What a neophyte is? Young animal. So you have this. How long you have that cold?
Since Friday.
You have fever, headache. Can I tell you something? That cold is going to be with you for the next 3 weeks.
That's wonderful.
3 weeks. Can you imagine that? It's a terrible cold going around. I've had mine now for 3 weeks. And this cough, it will get worse. More terrible. But I talk to them at the same thing. And then anyway, more details. Alright, so that's the what? Superior parietal lobule. Now look on this lobule, guys. Look, you see it? Look here. The extension of it on the medial surface is this. This is the extension of the superior parietal lobule. All of this thing you see here is the extension of the superior parietal lobule on the medial surface. All of this, you see this little square thing? It's called the precuneus. So write that down. So write that the superior parietal lobule continues on the medial surface as a structure called the precuneus. Okay, so let me pick out these things.
How do you spell that?
Cuneus. Cuneus. Precuneus. Look on this. Look. See here? Look. This thing here. You see it? And another way to look on it is this. Another way to look on it, guys, is this. Remember what this is? What is that? Paracentral lobule. Good. So this large area of cortex behind the paracentral lobule is the precuneus. Do you know what this is? No, this.
Oh,
That's the parietal occipital sulcus. So the precuneus is bounded posteriorly by the parietal occipital sulcus and anteriorly by the paracentral lobule. Beautiful. That's a hot. I think this girl going to become a neurologist. I see them going to the internal medicine, specialize in neurology. You can see it.
I'll make sure I'm considering you guys in your meeting.
You know how many neurosurgeons we have in this department? So you see it? This is the what? Precuneus. What is the precuneus? It is the medial extension of the superior parietal lobule. So what is the function of the precuneus? Stereognosis. Okay? Alright, beautiful.
You said it's bounded anteriorly by.
It's bounded anteriorly by the paracentral lobule and posteriorly by the parietal occipital sulcus. Okay? Now let me take this out and come back around here now, because we said this was the superior parietal lobule, and this is the what? Inferior parietal lobule. So this is the area of cortex below the intraparietal sulcus. So this is the intraparietal sulcus. So this is the inferior parietal lobule. You see that? Good. Now I want you to notice something about the inferior parietal lobule. Yes? Look on the inferior parietal lobule. The upturned tail of the lateral sulcus gone in there. The upturned tail of the superior temporal sulcus gone in there, right? Everybody get that? Now specifically, look, the cortex that surrounds the upturned tail of the lateral sulcus, this cortex here is the supramarginal gyrus. So that's these two pins represent the what? Supramarginal gyrus. And then this cortex now surrounding the upturned tail of the superior temporal sulcus, I'm going to put it in green, is the angular gyrus. And these two gyri are located in the inferior parietal lobule. You get that? Got it? Lisa, you get it?
So what's the cortex around the lateral sulcus?
Yes, that's the supramarginal gyrus. And don't say the lateral sulcus, say the upturned tail, right? Of the posterior limb of the lateral sulcus. Now, what's the significance of now of the supramarginal? Asking my friend this. So supramarginal gyrus and angular. What is it part of? The receptive language area. Okay? Receptive language area. part of the what? Receptive language area. Dale, what is the function of the receptive language? You're asking my friend Dale. Understand? Huh? Understand what? And what else? So no, asking Dale, I want him to put it in a nice scientific way. Good. Good. Understanding of the written and spoken words. That's what you must say. In other words, somebody with a lesion there. How are you this morning? Are you okay? You don't understand what they're looking blank. They don't know what you said. Well, maybe, I don't know, I'm gonna write it. Look at it. Blank, they don't know what you're talking about. Okay? So that person now, you get the paper, you take out the pad, you diagnose this person as having what? Receptive aphasia. So what are the three alternative words we can use? Receptive aphasia, fluent aphasia, or Wernicke's aphasia. Good. Now tell me now, what are some of the causes you think? What are some of the things that can cause somebody to develop that? What do you think? Based on your knowledge that you know. And when you say damage, what is not to Wernicke's area. Don't say damage to Wernicke's. You went to damage to what? To the receptive language area. That includes Wernicke's area plus the supramarginal and angular gyrus, right? Everybody get that? Remember now, the receptive language area is supramarginal gyrus and angular gyrus plus what? Planum temporale and the posterior part of Brodmann's area 22. Remember, planum temporale and the posterior part of Brodmann's 22 is Wernicke's area. So the other part of the receptive language area is Wernicke's area, right? Anybody asks you, show me where Wernicke's area is? He says, sir, it's right here in the planum temporale and the back part of Brodmann's area 22. So those areas on the superior, well, Brodmann's area 22 is on the lateral surface of the superior temporal gyrus, but planum is on the superior surface of the superior temporal gyrus. So listen to me now. So yes, so I don't like the word damage. Damage is not a medical term. Don't say that. You can say trauma, and when you say trauma, I could say, well, maybe a person get a bus head, or jump off a tree, or something impale them. You know, somebody flings someone, broke the bone and go right into the thing or whatever, right? So you could say trauma, yes. What else? A neoplasm. Not true. What's a neoplasm?
Like if the person has a neuroma.
No, but that don't complicate. Yeah, that's complicated. So what's a neoplasm? Just give me a general, simply. So neoplasm is what?
Proliferation.
You can say it doesn't have to be a cancer, though. It can be benign or malignant. Right, so benign or malignant growth. Right? Yes, so it can be trauma or a neoplasm. So in other words, when you go on the ward and the consultant asks you, don't say a cancer. And sometimes you don't want to say these things in front of the patient either. So you say a neoplasm. And they say, sir, it can be a benign neoplasm or a malignant neoplasm. So trauma, a benign process or a malignant process, right? And what else?
Stroke.
A stroke. And of course, remember, a stroke can be what? You do cardiovascular, it can be ischemic or hemorrhagic. Good. Ischemic or hemorrhagic. Or you could even say it could be thing too. It could be congenital. So you could start off by saying it could be congenital or acquired. And the acquired one now could be a stroke, a neoplasm, could be trauma, and so on. You get that? So they like when you present your facts like that. Okay? So, everybody get that? Good. And remember, trauma can be many things, gunshot wound, motor vehicle accident, and so on, right? Wife and the husband a fight and the wife chop him in the head. Right? Yeah, especially if he got married to a Trinidad girl, and those Trinidad girls are very aggressive. Yeah. They're not like the Jamaican girls who are very classy and so. Alright, come, let's move on now. Let's move on now. So look here guys, if I were to ask you now, come, if I were to ask you to succinctly, or I could say in a few words, tell me what the function of the inferior parietal lobule is. You're going to say, sir, inferior parietal lobule is part of the parietal lobe, so it's part of the general sensory association cortex, but specifically, it's part of the language area for receptive language. Okay? And you're going to say, sir, because the angular gyrus and supramandibular are located there. So it's part of the receptive language area. You get that?
We need to know, like, so we have numbers for.
Yes. Well, yeah, and I will tell you, you notice I've only told you one number so far, 22. I'm taking my time, you know, I'm judiciously giving out these numbers. I don't want to overwhelm anybody. All right, so that's that. You want me to drop? How is the calm? It's not letting up. It's not letting up. All right, so let's move on now, guys. Let's move on, everybody. So, good. So we just talked about the parietal lobe, specifically superior parietal lobule, inferior parietal lobule. Now look at this now. I am now going to open the lateral sulcus and peep in there. See now? So look here now. Look. I open it up, and look what I notice, guys. I'm going to turn around and show you. I'm seeing two gyri that are going transversely. So I've opened up the lateral sulcus and see I see two gyri there going back. These are the so-called. Abby, what? Abby not even making any attempt. Look, see them there? You know what these are? The transverse gyri. See the pin in them? See? And notice where they are on the superior surface of the superior temporal gyrus. So, see it? Lisa, I want you to look at this. See it? So these are the what? Transverse. Sometimes there are 3 of them. So the book said that there are 2 to 3 of them. See? These are the transverse gyri. What's the significance of these transverse gyri, Dale? It is the location of what? Heschl's convolutions. Huh? Superior surface of the superior temporal gyrus. So these things, you know, look here guys, you can help yourself a lot. Every time we have a class like this, you go home and sit down and read it up and you say, okay, let me open the atlas now and say, if I can see this thing that Solomon showed me. Let me look if I can find Heschl's convolution, right? And then once you feel like you have the basics that I just told you, so okay, let me see what Bar said now. And expand your knowledge. That's all you know. And you go on clear. Nobody can challenge you. Now look. This flattened area now behind Heschl is planum temporalis. So, so in green, let me use a different color. So in green, this area behind Heschl. Let me start on this side. Look. Area in green behind Heschl's is planum temporalis. Yeah, we can pose on everybody. Oh. That's what? Planum temporalis. See that? And so you're not surprised because remember now the association areas, the green ones here. Remember the association areas tend to be what? Close to the sensory area, right? Good. So those cortical areas that surround Heschl's is Wernicke's area. Okay? Planum temporale. Planum temporale, right? So what I could do now, guys, look. What I could do is put 2 more green pins. I can't find no more green pin. I could put, look, 2 more green pins round here, indicating the posterior part of Brodmann's area. I'll just use a pink pin. Right, so this posterior part where these two pins are, plus the planum temporale, are the two areas close to what? Heschl. So those are Wernicke's area. No. Brodmann's area 22 is all of the lateral surface. Not all of the superior temporal, all of the lateral surface of the superior temporal gyrus. Okay? So look, it's all of this. Look, it's all of this surface here. All of it go all the way around. 22. But the back part of the 22 now is part of Wernicke's area. And what is Wernicke's area for?
Receptive link.
No, it's part of the receptive. But what's the main function of Wernicke? It's the association cortex. Don't forget that. It's the auditory association cortex. So what's the importance of that cortex? Yeah, it makes you understand the significance of the auditory impulse, right? In other words, when I talk to you, and it fall on Heschl's, only thing that allow you to is hear what I say. You don't understand one single word yet until it goes to where Wernicke is. You get me? Good.
Can you show me that?
Hmm?
Can you show me that?
So what we're saying now is the two kingpins, those transverse diagrams, Heschl, and the areas surrounding, which is the association cortex, including this area here, which is this area here, which is the posterior part of parietal, area 22 here, and then this now inside, which is the planum temporale, and this is the posterior part. So all of that here is Wernicke's area. Okay, guys? Yes? So Daniel, tell me what you want me to say. Yes. Okay, so first thing what I'm going to do is put all the pins in Brodmann's area 22. All these pins are in Brodmann's area 22, all of them. Right? So all these pins are in Brodmann's area 22. Okay? But it's just the back part, it's just these pins alone contribute to Wernicke's area. The posterior part of Brodmann's area 22, right? Plus the planum temporale, which is behind Heschl's, which is down here. Okay? You get that? So you have to get that, get a picture, look on it, study it well. Because in the exam they like to put pins and ask you identify the area indicated by the green pin. Good. Remember what I told you now? So when we speak, Lisa, when I talk to you, the vibration of my vocal cords disturb the air molecules close to my mouth, and those going to start by oscillating. Those disturb the ones close to them until a wave is set up. That wave is going to continue all over the place and to get into your external auditory meatus, set up an auditory pathway, right? That pathway of several bus stops. It has to go through the eardrum, it has to stimulate the ossicles, and so on, right? And the final destination. Yes. So one of the bus stops is going to go into the what? The organ of corti for hearing in the cochlea. I don't know if you know about that, but there's an organ for hearing in the inner ear. The inner ear basically have two things in there. We're going to talk about that. It has something called the vestibule for balance, and it has the snail shell looking thing, which is the cochlea for hearing. Within that snail shell thing is the receptors for hearing, which is the organ of corti. And of course, if we try to go back to first principles all the time, all the sensory organs, the sensory receptors, the neurons in them are bipolar neurons. They have a peripheral process and a central process, right? So the peripheral process is going to mingle with the organ of corti, but the central process is going to take the information into the brain, right? We're going to take it into the brain. But it's a specific part in the brain you're going to take it. You're going to take it in the dorsal and ventral cochlear nucleus. We will talk about that. And then from the dorsal and ventral cochlear nucleus, we're going to get to our next station, then eventually inferior colliculi, and then from there to the thalamus, which part of the thalamus? MGB, and then from the thalamus, now everything comes out of the thalamus is going to go where? The cortex. Remember the thalamus is the great sensory relay station.
anything that's destined for the cortex has to stop first in the thalamus. And thalamus is like a secretary at your house. Every time the phone ring, she answer and decide, no, I'm not going to go and make this person talk to Solomon. Oh, he's not hearing this. Or, oh, he's sleeping, right? Right? So I'm the cortex. Oh, he's sleeping, whatever. And then no, so you call. You're my good friend. Oh, all right, I'll get him. What's your name? Oh, I'll call him. And she gets it, right? So she allows you now to come to the cortex, right? So the thalamus is weeding out things, decides who go to the brain and who don't go to the brain. You get that? So once the auditory pathway leaves the thalamus now, it is destined now for the brain. Which part of the brain? Heschl's convolution. You get that? The primary auditory cortex. And once you get there, you receive the stimulus. And so you hear it. It's a gunshot, you hear it. But the significance of the gunshot, you don't understand yet. Until Heschl's now pass it on to Wernicke's. And what's the importance of Wernicke's? Wernicke's is the auditory association. Wernicke's is the place that the first gunshot you heard is stored there. Everything about the gunshot is stored there. The pitch, the tone, everything about it is stored there, right? And the significance of it. So you hear a gunshot and guess what? Your heart rate go up, your respiratory rate go up because the gunshot is like outside and you start to sweat. And you ask yourself, how does a gunshot cause all of these things? And from the little neuro that you've read, you remember that one of the first area for fear and rage is the amygdaloid body, right? And remember, I told you that the general sensory association cortices, all of them, collect information. So the visual association, auditory association, taste, everything, send information over to the hippocampus and to the mammillary body, and to the amygdaloid body, sorry. So hippocampus and amygdaloid body. And then hippocampus now and the amygdala distributed to different places. Remember the hippocampus send it to where? Mammillary body send it to anterior nucleus of thalamus and to what? Midbrain tegmentum. And why is it sending it to the midbrain tegmentum? Because that's the gateway into the autonomic nervous system. Because the midbrain connect up to the pons and to the medulla. That's the brainstem. What's in the brainstem? The cranial nerve, motor nuclei in the brainstem. You get that? That's the parasympathetic cell bodies, nuclei are in the brainstem. And of course, look, the medulla pass the information on to the spinal cord. What's in the spinal cord? The sympathetics. You understand? So from the midbrain tegmentum, everything gets passed on to the autonomic nervous system. Remember that the center, the cardiac and respiratory centers, are in the pons and the medulla. Your heart rate go up.
So, sir, somebody who never heard a gunshot before.
Who is that person?
I'm just saying that. Someone wrote, well, never heard something like that. And you hear a gunshot. You just stand up.
No.
Yeah, so they won't wonder what is that loud sound. You know, even if it's an adult, a man, a 55-year-old man who comes from Utah in the United States, a rural part of Utah, you never heard a gunshot before, right? He would be interested to know what is that loud sound, right? And then find other people around him say that's a gunshot. And then based on their reaction, all of that gets stored in Wernicke's. Next time he hear a gunshot now, he will remember all of that response. The same sound he's going to hear, but plus he's going to associate the other things that come with the sound from what he hears from other people, right? And so now this 55-year-old man decided he wants to do medicine. Can't get into a medical school in the States and come to Jamaica. In the lab, he one-night study. And he heard a gunshot outside. And of course, people tell him that Jamaica is violent and all these things. This man starts sweating. That's that respiratory rate going up and all these things. You get that? You get that? Right, so that's the function now of what? Wernicke's area. And we say now, therefore, that when you think about it, the only place a schizophrenic can be hearing voices from is Wernicke's area. There's no other place, right? Because Wernicke is what? So Heschl's project information to Wernicke's, and Wernicke's allow you now to appreciate, the significance of this thing. And for some strange reason, this man has developed some sort of chemical imbalance, and now Wernicke is sending back information. Wernicke don't normally send information to Heschls. All of a sudden, Wernicke is sending a whole heap of information over to Heschls. Complicate everything, right? You understand? Hearing voices, and these voices are voices not coming out in any particular order. This is a voice that you did hear for the first time when he was 2. Then all of a sudden, we are next one when he was 16. You know, and then one when he was 12. And said it don't make much sense, but he's hearing them. Push the boy, lick him in the head. Who that? Where he come from? It doesn't have to be violent either. But remember, you see a lot of the schizophrenic, most of them, well, I shouldn't say most of them, but some of them are paranoid schizophrenics. You know? So those ones now, they're getting commands in them head. These commands are strong and they cannot ignore them. Right? Yeah, so what I'm saying is that these schizophrenics have this paranoid thing. When you sit down and talk to them, they tell you the government is spying on them and put microwave in the wall and all these things. You understand? So, and the interesting thing about it, when you study the USMLE, when you're doing psychiatry from Jamaica, anywhere you go, all of the schizophrenics said that the paranoid ones have the same thing. These people are following me, they're trying to poison me, and the government is putting things in the wall to listen to my conversation. All of them say, you understand? Sir, do you sometimes think people can hear your thoughts? Yes. So sometimes you try not to think, because you think those people can hear what you say. Anyway, come. Moving on now, guys. So that's that, right? So remember now, and in the exam, look, this hard to do. So what some of them do, sometimes I see them do, get a chalk or any piece of stick and put it in here to catch up the thing like that. And then put the pin now in Heschl's convolutions to identify the raised area indicated by the pin. You understand? And the next thing they might ask, and I'll just tell you, you know, essentially. So remember now, guys, you did a little bit of hypothalamus. And in your hypothalamus, you were introduced to afferent reference, right? So the examiner now will put the pin in Heschl's convolution like that. So the pin is in the transverse gyri, right? And the examiner will ask you, what is the main afferent? So the main afferents to the area indicated by the pin arise where? The main afferents, where they come from?
Forehead.
Huh? No.
It's on the forehead.
No, man, where the pin is in the Heschls, right? So it's in the primary auditory cortex. Let me just tell you a while ago. The 2 pin them in the primary auditory cortex, right? Good. So anything you want to go to the cortex must be coming from where? The thalamus. And you have to tell them which part of the thalamus is coming from. MGB.
What's MGB?
The medial geniculate body. What is that? So anyway, let me just tell you. I mean, no, I'm taking it for granted. And these things you'll hear, you know. You'll hear them over and over. You're going to do the auditory pathway. But let me just tell you something. I don't know if you studied thalamus at any point at all. Okay, so just by way of introduction, the thalamus is the great sensory relay station. Let me just say that. This is just introduction. Yeah? You're going to do this when you do auditory pathway. All sensations, guys, that goes up to the brain has to stop in the thalamus first, except one sensation. What is that? Yeah, smell. Smell is the only one that don't go in the thalamus. I told you guys that. So it bypasses and goes straight to the brain. You remember that? So you remember that the olfactory nerves, right? Their cell bodies are in the where? In the nasal cavity, where? In the superior concha. And then the axons pierce the cribriform plate and run in the olfactory tract, right? Remember that? Good. Good. And then the tract now will divide into a medial and lateral olfactory striae and go straight to the brain. No thalamus is involved in this. But every other sensation that wants to go to the brain
has to stop in the thalamus. No, but the thalamus now has several subnuclei. Write that down. So the thalamus has several subnuclei. So for example, the limbic system tends to project to which thalamic nucleus? Just think about it. Just think about this circuit of Papez. Hippocampus to mammillary bodies. Mammillary body can project to the midbrain tegmentum, or it can project where? Anterior nucleus of thalamus. And then that project to the cingulate gyrus to parahippocampal and back to hippocampus. So that's the circuit of Papez. But the two thalamic nuclei that the limbic system projects to is the medial dorsal nucleus of the thalamus and the anterior nucleus of thalamus. Okay? So in a nutshell, the anterior nucleus of thalamus is considered to be a limbic nucleus, and so is the medial dorsal nucleus. You get that? Huh? Good. Don't worry about that. We're going to go through that. I don't want to. Good. So let me tell you another nucleus now. Vision, for example. just in a nutshell. Remember now, look. So the receptors for seeing are in the retina, right? And then all the things happen, but coming out of the retina now, we have the optic nerve. And remember that the optic nerve comes out and crosses at the chiasma. And when it crosses, it gives rise to the optic tract. So the optic tract is that part of the optic nerve that's conveying the visual information. And that visual information from the optic tract going straight to the thalamus. Which part of the thalamus is going? LGB. So it's going to the lateral geniculate bodies. So the lateral geniculate bodies are thalamic nuclei responsible for what? Vision. And then since we already know the little thing that Solomon told me, that the thalamus is the great sensory release station. Anything going to the brain have to stop in the thalamus first. So when I ask, I said to you, the optic tract, go to the thalamus. And I say specifically go to LGB. Then I said, when it come out of the thalamus, where is it going? He went to tell me what? The cortex. But you know when you say the cortex, then he going to say what? The primary visual cortex. Not true. In the occipital lobe. You get that? Good. The same thing with sounds. Guys, the same thing with sound. When I talk to you, it sets up an auditory pathway, and one of the destinations is to the what? Thalamus again. It wants to go to the Heschls, but it is confined by this rule that says anything that wants to go to cortex has to stop first in the what? Thalamus. Does it go to LGB? No. It goes to the auditory nucleus in the thalamus. What is that? MGB. Right? Now, the dorsal column system that we like to talk about, right? Including the so-called spinothalamic. So the spinothalamic tract is a pathway that conveys what? Pain and I hear that you do spinal cord enough. So you guys must know these things. So pain and temperature is conveyed by the spinothalamic tract, and it is sensation. The dorsal column system is also sensation, and all of those sensory information going to the thalamus. They want to go to the cortex. Which part of the cortex they want to go? Paracentral gyrus. But before they go there, they have to stop first in the thalamus. Which nucleus? The ventral posterior nucleus. And not just one ventral posterior, there's a specific one that's called ventral posterior lateral nucleus. So we call it VPL. Get that?
Dr. Solomon, for the spinothalamic tract, is it crew touch as well?
Yes, crew touch. So half of crew touch is traveling in the spinothalamic as well. Yeah, all I'm saying, what we're trying to do is just to give you a little insight into the thalamus, right? So I'm telling you the different sensations now. So I'm saying now, our body, that pain and temperature travel together in a specific pathway that's called the spinothalamic tract. That goes to the, want to go to paracentral, but have to stop at the thalamus. Also, dorsal column system, we know, transmit vibration, sense, pressure, 2-point touch, proprioception.
Those have to go to the postcentral too, but they have to stop in the thalamus. And so those, along with pain and temperature, stop in the same thalamic nucleus, the ventral posterior nucleus. But those go to a specific part of that nucleus, the lateral part, so we call it VPL. Okay? Now, those same set of sensation from the head now go to the VP2, go to VPM. Write that down. So proprioception, so write that down. Okay. So proprioception, write that down, guys. Proprioception, vibration, 2-point touch, pressure, as well as pain and temperature from the head are going to go to the VP nucleus too. But they go to a specific part, VPM. So the ventral posterior medial nucleus of the thalamus receive sensory input from the head. Okay? Okay, good. So you see that, guys? So in other words, what I'm saying, everybody? Hello? Yeah, what's up? Okay, cool. All right, I'll call you soon. All right, cool. Yeah, so, wait, you were saying something, Daniel? Huh? Okay, cool. Yeah, so let's move on now, guys. So that's just a little insight, guys. There are a couple more thalamic nuclei, but those, I won't bother going to those. I've not even counted them. There's the pulvinar, there's the ventral lateral. All right, come, let's go now. So that's thalamus, right? And in fact, those nuclei given you are the more popular ones that you will come across in the MCQs and in the spotters, right? Those nuclei, the examiner can put the pin in some of them. Like the anterior nucleus, we can put the pin in that because you can see it. The pulvinar, you can put the pin in there. All right. So we were talking about what now? Right, the auditory pathway, and we're talking about Heschl, right? So we're moving on now. Moving on, guys. So, we also talked about this part of the frontal lobe, the prefrontal cortex. Remember that? Let's talk a little bit now about this prefrontal cortex. So we say the prefrontal cortex is the most anterior part of the frontal lobe. It is the part of the it is the part of the frontal lobe, guys, that gives our forehead the rotundity. And it is where our personality lies. So that's another important thing. And what I've just told you is not something you should take lightly. Because you can use what I've just told you now when you're taking a history from a patient, right? Because when you go to third year and you do medicine, there's a man called Dr. Gilbert there. And he asks the same question every time. You know what is his main concern? Where is the lesion? So you're going to say this man present with contralateral weakness of the lower limb. Where is the lesion? Right? And you're like, what the hell is this man asking me that for? Because when you think about it, look, this cortical spine, this precentral gyrus, everybody, this precentral gyrus that we talk about, we say it is the what? Primary motor cortex. So if you have a lesion there, the man going to get what? Contralateral weakness. The axons from here will leave our end where? In the spinal cord. So how are these axons going to lead from here to the spinal cord? What's the pathway they have to travel through? They have to leave the cortex and pass through where? The brain stem. You have to see the brain stem here. They have to pass through the brain stem. All of this bulb-looking thing is the brain stem. The top part is the midbrain. That's the pons and that's the medulla. Now the brainstem, write this down. Brainstem, right? Yes. So this is the brainstem. The top part close to the cortex is the midbrain. The big belly guy here is the pons, and this is the medulla. And in the medulla now becomes the spinal cord. So the brainstem, guys, everybody, you guys may say never heard it before. The brainstem, you can consider the brainstem. I like to consider the brainstem as the I-95 in the United States of America. You know the I-95? Anybody have drive on it? Yeah, but not just to all state. It is the highway that connects the south to the north. So what is the north in my analogy? The cortex is the north there, and the south is the spinal cord, is the lowest part. So sensations that leave the spinal cord and want to get to the cortex, there's only one road those sensations can walk on to get there. It's the brainstem, right? So let us go through now the different bus stops, just generally, that these sensations, for example, the dorsal column system and the spinal thalamic pathway have to pass through to get to the cortex. So they have to pass through the spinal cord, right? And then what's the next bus stop? The medulla, and then from there, the pons, and then the midbrain, right? And then once they come out of the midbrain now, what's the next bus stop? Internal capsule, right? But thalamus first, then internal capsule, and then now finally get to the cortex. So the take-home message you must write down: the ascending pathways to the brain have to pass through the brain stem. Okay?
The ascending pathways are sensory pathways.
Yes, the ascending pathways tend to be sensory pathways. So the ascending pathways have to pass through the brainstem to get to the cortex. You get that? Good. Now guys, the descending motor pathways, for example, cortical spinal tract, when they leave the cortex, the destination is to go to the spinal cord, to synapse on what? Ventral motor neurons in the ventral horn. And the axons of those ventral motor neurons will constitute what? Brachial plexus and the lumbosacral plexus. So those cortical spinal tract that's coming down, in order to get to the spinal cord, they have to pass through the what? Brainstem, right? They have to pass through the brainstem. So they have to pass first from the cortex. They have to pass through the where? Internal capsule, and then from there, midbrain, pons, medulla, and then the spinal cord. So this is what I want you to say. Once you write that. You write that. Now look at this now, guys. Everybody have that? Now look at this. So this is the brainstem of which I just spoke, right? This is the brainstem, right? This is the brainstem, guys. That's the brainstem. But look here, I'm going to turn it around, and this is still the brainstem. You get that? So why is it that the brainstem looks so different here from around here? Because this is the ventral part of the brainstem. You get that? So this is the ventral part of the brainstem, and this is the dorsal part. So this is what I want you to write now. The descending pathways, the descending motor pathways from the cortex. The descending motor pathways from the cortex descends through the ventral part of the brainstem to get to the spinal cord. So the descending motor pathways have to pass through the ventral part of the brainstem to get to the spinal cord. Whereas the ascending sensory systems now, the ascending sensory systems, they ascend through the dorsal aspect of the brainstem. Yeah, it makes sense. And what is the dorsal part of the brainstem generally called? The tegmentum. Yes? So they ascend. Huh? Yes? So the ascending sensory pathways pass through the dorsal aspect of the brainstem. Okay? So each of the three components of the brainstem I just mentioned, each of them have a tegmentum. You get me? You get me? So there's a midbrain tegmentum, the pontine tegmentum, and there's a tegmentum of the medulla. So we're saying that the ascending sensory system passes through the tegmentum of the brainstem. But the descending ones now pass through the ventral part of the brainstem. Look on the ventral part, look. This is the ventral part of the brainstem. So look here. You see this? Where the white thing is? It's in the midbrain. Remember, most of the first part is the midbrain. But this ventral part is known as the cerebral peduncles. See that? So the cerebral peduncles possess the descending descending motor systems. You get that? This big belly guy here is the ventral pons. Right? And that's where the motor systems are.
You said the cerebral peduncles possesses
The descending motor systems, yeah. You get that? And the big belly part of the pons, this is this big belly guy. Look, this is pons too, but you're not seeing a big belly here. So anytime you see this big belly, it means that it's the ventral pons you're looking at, right? And that's where the descending motor systems are. Once they come out of the cerebral peduncles, they now enter the ventral pons. And then look here now, this is the medulla now. I look in the medulla. You see these bulges? These two bulges on either side of the medulla. Good, yes. These are the pyramids. So the pyramids represent the ventral part of the medulla. And what passed through there? The descending motor systems, like what? Cortical spinal tract. See that?
What about the crus cerebri?
No, the crus cerebri is part of the cerebral peduncle, right? So remember, so we said the cerebral, I don't want to get into the details of it yet, but so the cerebral peduncle is further divided into some other thing, but we don't want to go there yet. But those crus are part of the peduncles, right? So those things we're looking at is what? Pyramids, and they're part of the medulla. Which part of the medulla are they? The ventral part. What parts in there? The descending motor systems. In other words, you can see now that the ascending sensory systems don't mingle with the motor systems. Motor systems are on one side, sensory systems are on the other side. You get that? And remember now, we're going to do these things. Each of them is their own topic. This is just a little introduction. Right? In other words, it's going to get easier and easier as we go along. We're going to explain them over and over again. You see how I teach, guys. I repeat the thing over and over and say the thing over and over again. Cerebral peduncles are these two big columns there. These two big columns at the top, midbrain, yes. What do what? What? No, there's no such thing. There's a superior colliculus and an inferior colliculus. But these are just the cerebral peduncles. In the cerebellum now, you have a superior cerebellar peduncle, middle cerebellar. But forget about those. This is the what? Cerebral peduncles, right? Cerebral. So the cerebral peduncles are part of the midbrain. Okay? Which part of the midbrain are they? Ventral part. What pass through those? The descending motor system. And by the way, for interest, guys, look, for interest, guys, for interest, look here. Guys, for interest, so we say, I told you that this is the what? Midbrain, right? And I said, which part of the midbrain is that? The cerebral peduncle, the ventral part. Now, if we keep to the ventral part, we come on the back now. That is still the midbrain. But what do you notice? You're seeing 4 bumps. You see one bump up there, and coming over there. See another one on the other side there. And then the other 2 at the bottom, that, and that. These are the 4 what? Yeah, so collectively we call them the corpora quadrigemina. The top ones are the superior colliculi, bottom ones are the inferior colliculi. Remember that the superior ones are part of the visual pathway, the inferior ones are part of the auditory pathway. So when I talk to you and you hear it, one of the bus stops before it gets to the thalamus is the inferior colliculi. And then from inferior colliculi now, then they go to the thalamus. Which part of the thalamus? MGB. And then from there now to Heschl's convolution. Huh?
You said
visual. Okay.
You said all 4 of them combined.
Yes, called the corpora quadrigemina. Right? Corpora means body. Quadrigemina, of course, means four. Alright? So, what we have done basically, guys, is a little geography. Alright? Yeah, so what I was going to tell you now, yeah, this is the dorsal aspect. So this is, look, again, Daniel, this is the ventral aspect of the brainstem, and that's the dorsal aspect. So look here, guys, look what you're going to notice now. So I take out these two pins, everybody, I take out those two pins, and we're in the what? Midbrain, right? And we're specifically in the most, you could say, top part, the midbrain. So when in anatomy, when you say top part, give me a word for that. Not because it's superior, but a better word is rostral part, or you can say the cranial, right? So what's above the midbrain now? The thalamus. So you see these two big things are the two thalami. See them? So these two big things are the thalami. See them? So these two egg-shaped structures are the thalami. You get that? Those are the thalami. And then, of course, you know from the little anatomy that you do, that between the two thalami, we have the what? Third ventricle. Good. The third ventricle. Alright? Fantastic. No, the MGB, LGB, all those things are thalamic nuclei. Thalamic nuclei. Alright, what time is it now? Good, we'll stop here.
Stop there.
Guys, you have a lot of